I'm just going to sort of go through some of the thought process on the analysis of non-union on CT. We just recently have our own weight-bearing CT scanner up. So this was referencing work that we did previously on non-weight-bearing CT, but I think that this is a huge opportunity for us going forward. So basically, what's the story with non-union? Is it there? Does it matter? So the non-union rates in the literature and on the AUGMENT pivotal trial that we were involved with are approximately 8 to 5% in the ankle, somewhere between 3 to 13% in the subtalar joint, some basically across the board in the hindfoot around about the 5 to 10% range. This was a paper that we did with Fabian Kraus when he was here as a resident and a fellow and after, and it was to look at what does it really matter if you have a non-union. Specifically, we were interested in this concept of asymptomatic non-unions. People say, well, don't worry, asymptomatic, they've got a non-union, it's no big deal. So, historically, patients would present back to the original surgeon. There was no longitudinal follow-up, and they say, I hurt. They get an x-ray, they see a non-union. So the whole concept of non-union was binary. It was either union, non-union, and it was reoperation, no reoperation. And so I think with CT, we can be more sophisticated than that, and I'm going to explain why. So could an asymptomatic non-union be okay? Could the majority of non-unions be asymptomatic, and is there a need to prevent them? It could actually be that if you do a longitudinal study, a whole bunch of patients have non-unions, and you could say, well, we just didn't know about them because they never complained. So we did a longitudinal study of the AUGMENT database, and it gave us the opportunity in the pivotal trial because they all had CT scans and follow-up. And so what we did was we wanted to determine the risk factors of non-union, but we also broke this group up into 4 groups. So it was those where the CT and the surgeon said they were united. So the FDA in their study actually wanted the surgeon and a composite assessment. They didn't believe that the CT was relevant because they have no historical data on it. So they wanted a clinical assessment of non-union as being the primary outcome criteria, and we felt that the CT was more relevant. And so we wanted to see how these compared. So there's 4 groups: patients in which the surgeon and the CT said they were united, patients in which the surgeon said they were united but the CT said they weren't, which would fall into the asymptomatic non-union group, ones in which the CT said they were united and the surgeon says they wasn't, and then the ones where both CT and the union agrees. So if you look at these groups, we can see here that the non-union group by CT at 52 weeks, a blinded assessment, showed significant worse scores for the AOFAS, the foot function index, and the SF36. So if we just went by CT and they were determined to have a non-union, i.e. less than 25% bone healing, then they did badly. If we then look at this group, so we've got these 4 groups I explained to you. There's no real difference in their demographics. So union on both surgeon and CT, union on surgeon and non-union on CT, and then non-union both surgeon and CT. You can see actually that there's a large number of patients. There was 299 in the group where both the surgeon and CT agreed, but a significant number, 52, that would fall into this asymptomatic non-union group, i.e. the CT said they weren't healed, but the surgeon said they were. Not many falling into this group where the surgeon felt they weren't healed and the CT said they were. And then 15 patients that where both the surgeon and the CT agreed. So it's interesting to me also that the only time the surgeon and the CT agreed was less than where the CT said they were not united and the surgeon said they were. But what was really important on this was the outcomes, and the outcomes were significantly lower in this so-called asymptomatic group. And so basically, the asymptomatic non-union doesn't exist. And so from this, we can then sort of come to the patients who we determined by CT to have a non-union, and we identified a number of risk factors. And so the bottom line was the CT was a better delineator for non-union in this particular paper. And it identified, for example, that you're more likely to be male if you have a non-union. You're more likely to have a higher BMI, and so be overweight. You're not more likely to be a smoker. You're more likely to have diabetes. And the joint distribution was as here. So the CT, again, showed differences in the demographics that did not exist if we just used the surgeon criteria. We also found that the non-union group had a slightly higher or better score before surgery, and obviously they did worse after surgery, as we demonstrated earlier. So in summary, non-unions cause a worse outcome, and the risk factors are male sex, overweight, ankle fusion, smokers, better preoperative score, and diabetes. So then the next question is, what's the relationship between percent fusion and outcomes? And so what we did was we looked at the reliability of CT in the assessment of ankle fusion. And what we wanted to look at was, first of all, how reliable is the measurement? And secondly, what's the relationship with outcome scores? We need a reliable measurement of fusion. And we found out that clinical exam and plain x-rays do not suffice. So in this particular study, we took the studies that had been previously performed, like the AUGMENT study, and we used the 24-week CT scan, and we then took the outcome scores at the same time and correlated them. So we also wanted to see from these CTs if there was good inter and intra rate of reliability. So if I measured the CT and determined its percent fusion, how good would be somebody else to do this, to come to the same conclusion? So in this particular study, we identified 20 patients that had 24-week scans with outcome scores at the same time, specifically an ankle osteoarthritis scale. So at 24 weeks, we took 3 people. They then had to read these scans, which was a laborious process, and determine the percent fusion. So they went through each individual slice and measured the percent fusion. We looked at the coronal and the sagittal images, this is the actual methodology. So we take a slice like this, measure the total joint width, measure the fusion width, and then subtract the unreadable area. So you can see here that the screw's in the way, and therefore that needs to be subtracted from the readable area. And then we determined the fusion width. So we then said, okay, how much of this is bridging callus? How much of this is total area that could be fused? How much can we not read? And then determine the percent fusion for each slice, and then we summed it for the sagittal and then the coronal views. This is how we assessed it, for example, on the coronal views. So you can see that there's no union between the tip of the fibula and the lateral side of the talus. So this would come in as roughly a 50% fusion rate based on this particular X-ray. And then obviously there's the area that's unreadable. And so we then obviously looked at these scans and the outcomes. We looked at the inter and intra-observer reliability. We did a regression model to look at the association between percent fusion and outcome score at the same time. What we found, first of all, that it was highly reliable, so that the inter and intra-observer reliability was up in the 93 and roughly up in the 90s level for both of those areas. We also found that there was significant correlation with the AOS score. So it didn't matter if it was on the coronal or sagittal view, there was significant relationship with outcome. Again, if we looked on both views, we got significant results on association with AOS pain at 24 weeks. So both the total AOS score and the AOS pain was even better correlated. This is the inter and intra-observer reliability. You can see a pretty tight graph. But this is also the relationship of the AOS score and percent fusion. So this, to me, is like a real telling slide. And if we come here, you can see this is 100% fusion. AOS score is such that the better the score, the lower the score. So here's the patients who had less fusion, i.e. 20% fusion, had high AOS scores up in the 80 range. And when we came down over here, we got the patients with low AOS scores and a high percent of fusion. And this had a high R-squared value. So to put it all together, conventional radiographs have low sensitivity in picking up non-unions, but it also, CT scan is improving the sophistication in which we can look at this. So for example, this is a weight-bearing CT. Sorry, this is a standing X-ray, and it looks okay, and then we get the weight-bearing CT, and you can see the non-union. So I would argue, first of all, that CT is the gold standard for assessing fusion following surgery. Secondly, that we've got to get away from this idea of thinking of non-union being binary, i.e. union, non-union, but think of it more as percent fusion. And the bottom line is the more you fuse, the better you do. So to me, going forward, when we're doing CTs of fusions, we need to actually sort of have an algorithm to predict how much fusion is present. Because if you, for example, got a 40% fusion in a patient a year out and they have complaints, you might consider adding some, not taking the whole fusion down, but targeting the area of non-union and grafting it, because that's having an effect on the patient's outcome. It also changed the way that we think about how we actually manage these patients, even in the primary fusion. Because if we can increase the fusion mass by more screws, better technique, or adding a bone graft or bone graft substitute, we're actually improving their outcomes. So it's not just about preventing the non-union and the repeat surgery. It's about making our patients all better and giving them better results so that we restore them to function. So that basically is the summary of my talk. And I think that we need to change the way how we think about non-union, and I think we need to change the way about how we think about its effect on outcomes. And I think that weight-bearing CT is a great opportunity to move forward to potentially create the algorithms to look at how we actually measure percent fusion, and then change how we manage our patients and also how we assess our outcomes. Because I think if we just look at, for example, outcome scores or surgeon assessment, we're not going to get a true picture of the effectiveness of our surgery. And instead of clinical outcomes and surgeon-rated assessment of outcome, the primary outcome in ongoing studies in assessing ankle fusion should actually be percent fusion by CT. Should be our primary outcome measure, not other scales. So anyway, I open that to thoughts and discussion, but I think this is a really exciting opportunity for us going forward.
I'm going to try and make this as clear as possible, but it's really no big deal. This is about joint space narrowing. So we've been analyzing our radiographs for ages like this. We're looking at for a diminution of joint space in our patients who have arthritis, and that's how we assess a cartilage impairment in our patients. So because weight-bearing CT gives us an image of how weight-bearing influences the position of our bones in our feet, we can now have access to much better information. So what distance mapping is, it's a 3D map of joint space narrowing in every single joint in the foot and ankle. So this was just an introductory slide. I want to thank Professor Ziegler from Drexel University in Philadelphia, and he's an academic member of our group. He was one of the first ones. I think he was the first one. And this is the first collaborative project that we've had with an academic member. So I encourage any single one of you who wants to become an academic member to just apply, and we'll be more than happy to collaborate. So the introduction is that foot and ankle deformities are driven by forces. And we all know that deformities are related to different kinds of pathologies. For example, the varus deformity of the hindfoot is related to ankle instability, ankle varus, varising arthritis, etc., etc. Valgus is associated with pes planovalgus, tip post dysfunction, etc., etc. So it's the forces that are created by offsets in our in the way that our foot is touching the ground, and on the way that the forces due to body weight are applied on the ankle joint that create those pathologies. So Martin has told you about the work that we did on hindfoot alignment, and what we did was to create a specific three-dimensional biometric tool to measure hindfoot alignment using weight-bearing CT. Because this revolution of weight-bearing CT is really huge, and we all intuitively think that it's great, but we have so much more data available now that we don't really know what to make of it. So we need to invent new tools that apply to the three-dimensional space. And angles are in only one plane. They are defined by 3 points. That defines a plane, so that does not apply in the 3D world. And if we keep on thinking like this, we are missing all the three-dimensional information. So the weight-bearing CT was one of the solutions to create such a tool. So we published this last year in Foot and Ankle International. And this was the validation of the concept and the first study on about 150 feet. And we found that the intra and inter-observer reliability of this measurement tool was excellent. And we found the normal value for this foot and ankle offset, which is around 2%. And it's concurrent with past literature and what we knew about hindfoot alignment. We always knew that there was a slight valgus and that this was the norm. So this is the tool itself, and I don't know if I can show you here, but anyway, so what we're measuring basically is the center of the architectural or mathematical or geometrical center of gravity of the weight-bearing plane of the foot, and how it is offset with regards to the center of the ankle joint. So basically, we are looking at if we're walking beside our feet or if we're walking on top of our feet. We also did a very nice study with Magnus, who has a built-in pressure sensor inside his weight-bearing CT, and we were able to show that the actual center of pressure is superimposed with this point and this calculation that we are using for this measurement. There is a movement in the anterior-posterior positioning of the center of pressure, but not in the medial-lateral plane. So this is joint space narrowing. This is what we were talking about. There was a publication in 2005 by Corazza et al. Who did a cadaveric study and who demonstrated partly that there is a correlation between distance maps and pressure inside the ankle joint. So this is why distance maps is a great tool, because it gives us an indirect view on the pressures that are acting inside the joints. So this is what it looks like, and of course, once that we've segmented the bones and that we've applied the algorithm, you can play around and you can present the results whichever way you want. So this picture is beautiful, but you can do anything you want, really. So our aim was to investigate the usefulness in hindfoot deformities, and we hypothesized that distance mapping was efficient in finding different patterns between hindfoot varus and hindfoot valgus. And normal. So we had 30 feet, and 10 of them were valgus, 10 were normal, 10 were varus. And we discriminated them using the foot and ankle offset measurement. So the first stage is to segment the bone. This has to be done manually. So for each slice, the outline is drawn by the investigator, and then the computer adds up all the slices, and it gives us the volume. Then the volume is smoothed out. And this is, I want to stop on this, but this is one of the limitations that we acknowledge because this is partly subjective. So there is an investigator, and he does some modifications on the volume, which are standardized. So because it's random, it does not influence the measurements, but it's still some subjective influence on the volume. So softwares are used for that. And then there is another software with an algorithm, I won't delve into the details, but that measures the smallest distance between two voxels within the joints. And those are the typical distance maps that we obtained for normal valgus and varus cases. And there are some really cool features that we know of intuitively, and that distance maps gives us a greater insight. For example, if you look at the valgus case, you can see that there is very strong approximation between the second and third metatarsal bones and the second and third cuneiforms. And we kind of know this intuitively because we all have cases of people with hallux valgus and they have medial arch collapse, and we know that hindfoot valgus is also associated with hallux valgus. And here you can see that clearly the distance maps show that there is approximation in the case of flattened arch. So this, if it's indirectly related to pressure, can explain why there is wear and tear inside these joints and why we often see cases of midfoot arthritis with these patients. So to analyze the results, of course, a distance map is great, but this is a proper scientific study, so we need to give some numbers, some proper numbers. So what was done was to divide the joint surfaces into areas and then to analyze the values of the distances statistically. And what you can see is that we have the normal values in the middle and then the values of the distribution of the distance for valgus and varus cases. And this is only the ankle joint. This is why this presentation is always difficult to do, but we can do this for the 34 joints in the foot and ankle. So I could talk about this for 2 days starting now, but you'd all fall asleep. So just looking at the ankle joint, what you can see is that in the valgus there is external rotation of the talus within the mortise. And you can see this if you look at, so it's the second picture starting from the right, and you've got the valgus, normal, and varus. And if you screen down from valgus to varus, you can actually see the approximation between the talus and the tibia on the medial upper aspect of the talus bone. So that is the green and blue spot that you can see on the third picture down there. But every single voxel, you can actually do this, and you can actually work out how the bones move in relation to each other with weight bearing and with degenerative disease. This is the subtalar joint. So basically, looking at the colors, what we can see is that effectively in valgus cases, there is internal rotation of the talus with regards to the calcaneus bone, and inversely so in cavovarus configurations. This is the Chopard joint, which also is concurrent to what we know, and I won't each time go into the details, but here we have the mid-tarsal bones and the tarso-metatarsal joints. So because those joints are more numerous, we found less discriminative power in the maps and also in the numbers. So as a discussion, this study confirmed our hypothesis. So we were able to distinguish different patterns between valgus and varus hindfoot deformities. The limits was obviously the size of the population, the subjective smoothing process that went on, And also, this is joint space narrowing. So if we have, for example, a cartilage lesion which is only on one side of the joint, we won't be able to discriminate that. We will only see joint space narrowing. In terms of ankle and subtalar joint behaviors, we found that in various cases there was dorsiflexion of the talus, and there was internal rotation with regards to the calcaneus. And it goes the opposite way in the opposite deformity. What the distance maps give us is vision on joint congruence. And we all know that joint congruence is the major factor of cartilage degeneration. So this is just a picture illustrating the movements that we can derive from the distance maps. This is just to illustrate incongruency of the joints. This is what happened in the Chopard and Lisfront, and what we could also see in this configuration in valgus cases was a distraction, so an increase in the distance maps in the first cuneo metatarsal joint. So that's also an image, an indirect picture of first tarsometatarsal joint instability. So in conclusion, we think this is a very innovative technique. It's non-invasive. So now if you want to have an indirect measure of pressure inside a joint, this can work for you. Of course, it's indirect because you also have, from a physics point of view, to take into account the elasticity of the cartilage, of the soft tissues. So it's an indirect measure. It is, of course, not yet available for clinical use because it's impractical because of the segmentation time. It takes about 30 minutes to process the bones in the hindfoot, and it takes an hour and a half to process all the bones in a foot. So it's impractical for clinical use, but we hope that we will move forward on that. So I thank you for your attention. I would like to thank again Professor Ziegler and our co-authors.
And so thanks for the opportunity to speak. First and foremost, welcome to Boston. It's nice to host everyone here. And I have no disclosures relevant to this talk. And so we talk about the ankle syndesmosis a lot because it's in a good percentage of ankle injuries, 11% of sprains, and an even higher amount potentially of ankle fractures. And it's often a reason for reoperation, either due to failure to diagnose, or maybe it's diagnosed and malreduced, or in the setting of inadequate fixation. And it's important to note that the bony anatomy of that we think of the syndesmosis as a ligamentous structure, but the bony anatomy matters. It matters a lot, and it has variable anatomy. And by that, what I mean is that the concavity of the incisura varies among people. And so because of this overlap, these different morphology, injuries can look different. What may look like an injury in one person may actually be a normal morphology with a shallow incisura. And so it's hard to diagnose subtle injuries when it comes to the syndesmoses. And so I'm not talking about this woman, someone who slipped on ice, clearly had a fracture, and the syndesmosis is widened, so in addition to fixing the fibula, one's going to place syndesmotic screws. I'm talking about a gentleman like this who slipped on ice, had a Maisonneuve type pattern, which is often missed initially in the ER. But then you get a weight-bearing CT scan, and that's what allows you to see the subtle asymmetry. The beauty of the weight-bearing CT is that you get cross-sectional imaging under physiologic load. And so this person underwent operative fixation despite being told early on that, oh, you just sprained your ankle. And so I want to show another gentleman. This is a 20-year-old male who fell down some stairs and thought he had simply sprained his ankle. About a month later, in his college setting, he went to the health services and obtained an x-ray and was told he had a fracture, or that it was negative for fracture. But already one sees a little bit of subtle calcifications within the syndesmoses. This was still during the semester, so he showed up in my office a number of months even after that. And as you can see, the proximal fibula looked reassuring. But what's that HO forming in the syndesmotic region, and how do I assess that further? And so that's where a weight-bearing CT can be incredibly useful. You can see that the asymmetry that you see under physiologic load at the distal tibiofibular articulation. And you can also see that the HO is forming posterolaterally. And so he ultimately underwent an excision of the HO and fixation. And so this is the problem with the syndesmosis. We see a lot of ankle sprains, and when we think of a high ankle sprain, we start by assessing it clinically. And we look at prior ankle injuries. What was the mechanism? Syndesmotic injuries tends to be external rotation injuries. So they have pain along the syndesmosis, but there's not one diagnostic clinical test, especially as the injuries get more subtle. And so we have things on our physical exam that we try to use. We have external rotation stress tests. We have calf squeezes. We have cross-legged tests. I would argue that I've added in my own practice the A to P and P to A shuck test, in which you take the fibula between your fingers and you shuck it back and forth. But they're all low sensitivity and specificity, and it's certainly not validated to reflect the degree of injury. And the only thing we know is that the higher the tenderness to palpation, the more likely that there's an unstable injury. And so standard radiography, we've talked about a lot of measurements, and what's most commonly used is not the tib-fib overlap, right? Because I just showed you that the incisura can be shallow, and so you can get fooled by an overlap. Right? And so that's why we often rely on tib-fib clear space, and the number 6 millimeters is often thrown in there. The medial clear space is often thrown in, and sometimes we get contralateral films, right? We look at the other uninjured side. But because of the anatomic variability, and we may miss subtle injuries. And so then we try to add dynamic stress radiographs. We look at weight-bearing or gravity views. We look at lateral stress tests in the OR, and in the clinical setting, the external rotation test has become a gold standard, but as I'll show later, that may actually not be the right test to use. And here's the issue. There's pretty good cadaveric data that shows that as you resect ligaments, the external rotation test is testing the deltoid much more than it's testing the syndesmotic. So it's a test for a medial injury, not necessarily a high ankle sprain. And in this specific cadaveric radiographic study, you see that as soon as the deltoid was cut, that's when there started being significant changes to the external rotation test. On the flip side, the cotton test is probably better for syndesmotic injuries. Here, in this cadaveric study, which subsequent data has supported, you need all three syndesmotic injuries, the AITFL, the interosseous ligament, and the posterior, the PITFL, to be injured to generate instability, but it's probably the most reliable test, except I beg you to find me a patient that wants a tenaculum put around their fibula in the office in order to have this diagnosed. So it remains largely an intraoperative test. And our own research at our lab at Mass General has looked recently into the role of arthroscopy. And we've been fortunate to have some publications recently about this. And indeed, it confirmed certain things. The cotton test works. That instability can be in multiple directions. It can be in the coronal and sagittal plane. And it showed that all three ligaments need to be injured in order to generate instability. But again, then we're talking about a trip to the operating room. And so the reality when you think about the clinical setting is we don't have a really good test for syndesmotic instability, especially as they become increasingly subtle. And so that's where CT has started to be examined. This specifically was a study looking at 14 patients with injury. This was non-weight-bearing CT. And they found that, for example, the angular difference around the fibula creating a tangent between the fibula and the tibia, the angle becomes smaller as the fibula starts to translate laterally relative to the tibia in 11 of 14 patients. Taking it even a step further, they found that if you just measure the area, so rather than just thinking about distances and angles, this is a measurement that's not always readily available on a standard PACS viewer, but maybe we should be measuring area, that in patients with unstable syndesmoses, they found that the area between the distal tib-fib articulation was larger. And then some syndesmotic measurements have started coming out with weight-bearing CT. This study took 32 uninjured patients. And they got a weight-bearing CT with the ankle in multiple positions, in neutral, in external rotation, and internal rotation. And what I conclude from this study is I don't know if the specific numbers matter so much as they show that the fibula, the relationship does change, both with weight-bearing potentially, but also just with movement of the ankle. But they also showed that there's a lot of inner subject variability. And so when we talk about measurements like 6 millimeters of tib fib clear space, realize that we're talking about an absolute number that we're applying to everyone, when in this study there was very high inner subject variability, but low intra-subject variability. And so this underscores the need, if you're going to get a CT for a syndesmosis, to get one of the contralateral side. And that's generally done easier if you have a machine that just does both at the same time. Another study that looked at weight-bearing versus non-weight-bearing CTs in 9 uninjured patients found differences in fibular translation. And these were not huge distances, but remember, these were uninjured ankles. And so maybe that changes as the ankle gets injured, and that's one of our lines of research. And so I show a case example of a 28-year-old male. He fell off a roof while trying to shoot coyotes. This is a true story. The coyotes won. And he presented with right ankle pain and diagnosed with a sprain and was initially treated non-operatively. On the lateral view, however, there was a little bit of an irregularity in the posterior malleolus. And so prior to him coming to me, he had had an MRI. And clearly it shows changes to the ligaments, the AITFL, and there's damage to the syndesmosis. But the problem with an MRI is realize that you're asking a different question. It shows injury. But we don't fix the syndesmosis because of injury. We fix it because of instability. And that's a very important distinction and an inherent limitation to an MRI. So I got a weight-bearing CT scan, and that's when you can start seeing the distances. The numbers don't project quite well, but on the right injured side, you see 6 millimeters versus 3 millimeters at the distal tib fib articulation. And so he underwent surgical debridement and then fixation of the syndesmoses. Similarly, a 53-year-old male that slipped on ice was told he had an ankle sprain. And again, a very subtle, if you look closely at the posterior malleolus, a little bit of an irregularity in the back. And so I sent him for a weight-bearing CT scan. And again, now under physiologic load, you're seeing an asymmetry. And so he also underwent surgical fixation. And here's another example of a 40-year-old female twisting injury to the right ankle. Again, you see the posterior irregularity. And notice on the left, on that picture there, that there's not a huge amount of overlap, right, between the tibia and fibula. And so the radiology read before she ever came to me was posterior malleolar fracture, mild widening of the distal tibiofibular syndesmosis. So let's go to the operating room, right? But you get a weight-bearing CT scan, and they're relatively equivalent. And so I would argue that it's not always black and white, right? I would have predicted that this patient may require surgical fixation, but in her we're proceeding with non-operative management because I, under physiologic load, cannot show an asymmetry. And that's where I feel more confident doing that with a weight-bearing CT than I do with a non-weight-bearing CT. And I bring up this arrow because this is why her incisura seemed narrow. Sometimes if you think about the beam catching it just right, you can see less overlap between the distal tibia and fibula. And so in summary, I think syndesmotic instability can be a very subtle finding. External rotation views, which are available to us in clinic on standard radiographs, primarily test the deltoid based on cadaveric studies. A cotton test is probably better for the syndesmosis, but it requires something like arthroscopy. A shuck test in clinic is what I've used in more and more, which is you grab the fibula and move it back and forth. And weight-bearing CT may be useful to diagnose instability, though that role needs to be further defined, and that's why these study groups are so important. And then the other part is you must compare to the contralateral side. There is high inner subject variability, but low intra-subject variability. Thank you very much.
Okay, it's a very pleasure and honor to be here with you. And I want to thank Martinus, Cesar, Arne, and all your group to invite me, and Ellen, Jim, and David to make this possible. I think it's a great opportunity for me to share our initial thoughts of our initial utilization of a weight-bearing CT machine in our institute. We are a group of engineers that are sharing this opportunity with our clinicians. I think I have to take here the support of this community, which has been built up a few years ago. We have run, it's the International Foot and Ankle Biomechanics Group. We have run the first conference in Bologna 10 years ago, and we have taken, our biannual meeting all over the world. We have taken the last in New York a few months ago, and we are arranging for the next in São Paulo, and you are all welcome to come and join us. I think this new technology provides both to your community and to our community a great opportunity to make terrific progress in this respect. So in our institute, we do orthopedic treatments for many years, and we try to take our long tradition together with the best possible technology all together. In our movement analysis lab, we have been using a number of different technology, starting from motion analysis to 3D fluoroscopy, just to identify in a patient the planning of the correct treatment, the supporting to support the prosthesis implantation, to monitor the functional performance, to making in case early prognosis of the treatment, and to optimize the device. And we are recently intrigued by the fact that a number of additional technology are taking us to the chance to define personalized treatment to our patients, and we are fully involved in this. I don't think we need to convince you about the value of the weight-bearing assessment of our patients. I came back to our logo, and you see the ground reaction force under the right foot and on the left foot. I think that for anyone involved in functional analysis, the assessment of the weight-bearing is fundamental, and we might even call our lab the weight-bearing lab. The context of personalization of the treatments is very intriguing for us, and you certainly are familiar with surgical navigation and patient-specific instrumentation already. And I think that there are large room of improvements, particularly where there are small joints where have demonstrated limited indication for joint replacement and satisfactory clinical results, and particularly foot and ankle needs to make a few steps forward. We are lucky enough right now to have in front important progress, both in joint modeling, in additive manufacturing, which provide us the possibility to print out a single device for our single patients. But for doing that, it is really necessary the medical imaging. So I'm going to very quickly, hopefully, to a few studies that we have in progress in our institute. And the first one is, in fact, the possible customization of total ankle replacement. With our friends common friends in Drexel, we have done the exercise of looking at the number of ankles from specimens. We have taken scans from these. We have made model from the scans. And over these, we have designed a number of possible different solutions for the artificial articular surfaces. These were taken back on the original ankles to compare and to show the results. A few preliminary results has been published already, and a number would be shown in the future. And for doing that in real patients, the condition in weight bearing, the most realistic for our patient, would show us the more realistic and important a condition of the bone architecture. What we can do now, in fact, is to test the new possible designs to make, in case, sizing and personalization of this device, and to do virtual implantation, which seems to be trivial, but it is not. We were lucky to have in Bologna a very good team of technologists in 3D printing. They are able to optimize the parameters for these design, for which we are now considering a number of possible different morphologies for the interfaces between the prosthesis and to the bone, starting from regularized geometries, but looking also to replication of the trabecular bone. And they have all the machine learning experience to do mechanical tests, and we are now running in our institute biological tests as well, comparing the potentialities of these interfaces. The second study that I'm going to show you with a little bit more details is about the quality of the bone models to be able to make the customization of the devices. Because of this new technology in our institute, what we wanted to do is compare these with the current 4 technology that we have been using in our institute. So we have taken a single leg specimen. We have taken these to our 5 different medical imaging technology. So basically, to be sure that the object was the same, we have taken the specimen in a cast, and we have fixed a number of fiducial markers which would imply both a plastic shell and a jelly ball to be then identified both with CT and MRI. And this has been taken into the machines. So we've been using our standard CT, our dual energy CT, the cone beam CT, and the 2 MRI that we have in use in our hospital, the 1.5 Tesla and the 3.0 Tesla. We have, of course, segmented all these images. From CT, we have taken bones and markers, and from MRI, cartilage and markers. And geometrical models of all this bone has been reconstructed. We have also used 2 different registration techniques by relying on the balls on the cast. These are called the singular value decomposition technique, which is based on the known cluster of markers. And we also used the shape matching technique for comparing clouds of corresponding points of markers. That has taken us to reconstruct not only the bones implied, but also the level of cartilage in between. Of course, we were not able to distinguish those of the tibia and those on the talus, but at least the entire cartilage in between was characterized. Distance map, we have used these to characterize the quality of these images. We've been heard about that from Dr. Lintz, and this was done in the bone-to-bone comparison, and also in cartilage-to-bone comparison. And as they have done, we can do that in a joint concept when the 2 bones are compared. The other exercise that we have done is to define a number of geometrical parameters which are fundamental for the design of our total ankles in collaboration with our friends in Drexel. So the results, very quickly, by looking at the balls in themselves, the cone beam CT have shown the best results in the matching. Better than the previous, the other 2 standard and dual energy techniques. In the bone-to-bone comparison, using the single value decomposition registration, the registration in itself was very successful in all these comparisons. A slightly better result has been shown by the standard and the dual energy CT. But by looking at the cartilage to bone models with SVD registration, we have observed quite a better performance of the cone beam CT together with the 3 Tesla MRI. That has shown the best reconstruction between the bone models and the cartilage in between. This for both the registration techniques, which is an important information for anyone interested to have again, a musculoskeletal model of our joints, which would imply the bones from CT and the cartilage from MRI. It is also been interesting to look how huge can be the difference with this technology when we work out geometrical parameters for our design of the custom implants. So these are, for all the possible combination and the number of parameters to be calculated, the maximum of the values and the minimum. Sometimes there are even 50 millimeter difference. These are, arc of circumference, where a little difference, in the cartilage can be, in fact, affected, the final result. But, for any customization process, that should be taken very carefully. A third study, which is a little, more dated. These are cases performed by our Professor Giannini a few years ago for severe degeneration, actually for severe injury of the ankle. A number of cases are now under design to design the talonavicular implants to replicate exactly, the injured ankle starting from the contralateral side. What we want to point out today also, in addition to this facility, is that there is a number of biomechanical facilities that we are using, which I believe would make a great impact in the utilization of the cone beam CT because of the synergy between all these measurements. So in this subject, for example, we have done gait analysis, video fluoroscopy, and now we are taking, advantage of this technology. Another interesting study that we have started is on the diabetic foot. We've been collecting baropodometric measurements together with kinematic of these feet by projecting these markers on the pressure platforms. In a way, we can calculate, the possible, the area of possible risk of ulceration where there is these maximum peaks. And now, with the combination of a number of these with the cone beam CT, we have also the corresponding 3D architecture of the bones. And I think that the association between these measurements would provide very interesting results. Don't think you need to figure out what we are showing now. So this is a female feet under severe deformation, for what is 12 centimeter high heel shoes. Well, she is an orthopedic surgeon, so she knows what she does. But again, it is, of course, very interesting for us to see the effect, and we want to study this together. Not only in terms of changing of the morphology, but also in the larger changing of the plantar pressure with these instrumented insoles. We've been involved in kinematic analysis of the foot, and we now want to take this chance to look at the difference between what we've been measuring with external markers with what is inside the foot, the underlying bones. So this is another exercise which would tell us a number of information. It is also interesting to see that finally we have 3D measurements under load, and this is something that we've been struggling with because of the limitation of the external measurements. So we now have the potentiality to combine these two, and this, I think, is very important and also relevant, an opportunity for these two communities to share thoughts and results. It is the most recent one. And perhaps the last exercise, but I call this study number 0 because it would provide the fundamental information to all the others. What we want to do, as mentioned today already, is to characterize in a semi-automatic way the geometry of this bone architecture. And because we've been doing that with the kinematic analysis, we think that we might provide our support in doing this. So basically, we start from data set which is given in the instrumental technical frame. Of course, we can't understand much about that unless this is taken on an anatomical reference frames. So a foot anatomical reference frame was designed, and all the models were transferred in this reference frame. We can then take every single bone and we can apply the principal component analysis to identify the major axis of the geometry of this bone. Basically, we can identify more or less a more longitudinal axis, a mediolateral axis, and the anteroposterior axis. Knowing that, we can identify automatically a number of anatomical landmarks from which, and also can calculate long axis of the metatarsal bone, for example, and using either the principal component analysis, the anatomical landmarks, or the anatomical axis, we can define anatomical reference frame according, to our standard or to your, consideration or your needs. Doing that for at least a couple of segments, we can calculate joint angles in terms of relevant orientation. If you do that for the entire foot, and this is actually taken from our first exercise terminated a few days ago, you can have an automatic identification of the entire foot, and that would be very important to analyze a large number of foot in an objective way without the intervention of the single operator. Good. In this very quick presentation and in this very short time in which we've been using this machine, we have put together a number of ideas, and sorry if this has been solved or addressed already. If I have not too much time, Martino is looking at me. Well, you can take a picture and write to me, perhaps. Well, what I think we have obtained already and established is the value of the 3D surfaces and 3D measurements of the foot under load for any process of clinical analysis, of course, but also biomechanical design of the orthotics. This can be combined with MRI for the analysis of bone models. This is a project which is not a pain on the neck as it was a few years ago. But I think we have sooner or later, if not done already, standardized these measurements, because these must be repeated in a number of patients over time, can be compared between population, between normal and pathological subjects. So the measurement of the posture and the plantar load would be fundamental. I think it is also very important to make this geometrical characterization, and it's also fundamental to combine these with the current biomechanical measurements. This was very difficult and very expensive until many years ago. Now you can buy, pressure platforms and kinematics a system with a very short small amount of money. So the combination of the two, I would suggest it is another fundamental step, and we can support this if you want. A number of further exploitation, already. and I go to the conclusion by acknowledging also the reconstruction of this foot that you have seen, in the original shape, and I shall recognize this brilliant student from Ghent, which has been, said to us. He has done a great job by segmenting this foot within the shoes, by looking and segmenting the foot inside, which would provide us, a lot of information. I thank you for your interest in our work, and I can take a question from you. Okay, thank you.
Thank you so much for the opportunity. Thank you all for being here this late. I'm going to show a little bit of the studies that I'm still doing at HSS. I have 1.5 weeks to go. Lot to write, but I gave this talk probably 1.5 years ago in Europe. At that point, we were just starting, and I wanted to keep the same title, so just to show the progress that we made. So it's pretty much the same title of my talk 1.5 years ago. So I'm a part of the board of the WBCT study group, and I'm also a consultant for Curvebeam. When I started this, flat foot is one of my passions for sure. So when I started this, since it was a new imaging technique, I wanted to really take each step at a time and start with the basic, improve basic concepts first before you go into the more details and the dream of having the dreams getting close. The Professor Leardini just showed. But so what I first studied that I wanted to do with the flat foot deformity. So in the X-ray, we have thousands of measurements that we use to evaluate this very complex and three-dimensional deformity. And the concept of the study that we ended up publishing at JBJS was really simple. When you put weight, does it change the measurements? So we have that, we know that for X-ray, but we cannot assume that that's going to happen for a new technology. So you have to show. And so that was the simple. So I wanted to start simple, and we started simple. We did a bunch of measurements, and I'm not going to go into the details here. You can read the paper. And then I wanted to show once we demonstrated that it was possible to do the measurements in the weight-bearing CT in a reliable way, I wanted to show if do we need experts to be doing this, or can we use healthcare personnel to do the measurements for you because they take a lot of time. In my paper, it's not part of the data, but it took about 25 minutes for you to do all the measurements. We didn't need to do all the measurements, but we did a lot just to have the data. But then we published showing that medical students, residents, and experts could do the measurements in a similar fashion if they were trained for that. We also evaluated hindfoot alignment comparing with clinical assessment that we know it's very subjective. This study is under review. It's going to be published soon, I hope, at least. But I also want to be a dreamer about this. Like I said, it's one of my passions. And I'm pretty sure that the most important thing that we have to answer, and that's the provisional title of this. This is not written the whole paper yet, but this is the provisional title. And I had a bit of a fight with Dr. DeLand and Dr. Ellis because they said, you can't keep this title. We're not showing that. But then they agreed with me that that's the answer that we want to answer. That's the question that we want to answer. Which are the patients? Because some people have flat foot and they don't hurt. At first time they come to your office, they're feeling something, otherwise they wouldn't be there. We would assume that. But how do you know if this patient is going to collapse? That's the question that so when do we have to pull the trigger and go into the surgical treatment? We don't have that answer. And unfortunately, as you're going to see, my paper is not going to be able to answer that. But that's the long-term objective, and that's what I want to work in my career to answer the question. And so because of the time, I'm not going to go into the details here, but flat foot, it's a real Pandora's box. Stage 2 deformity, if you just go into the staging, if you go to stage 2, you have like 3 3,000 types of stage 2. And so for me, the classifications are old. We can't really use it, and that's part of what I also want to do, kind of work into a new classification system. But the thing is, we don't know what happens first. We know that there's bone malalignment, and we know there is tendon and ligamentous insufficiency, but we don't know what happens first. We were taught that posterior tibial tendon insufficiency would be the main player in the game, but it might not be, as we're going to show here. So Dr. DeLand and HSS have published it before about this. And in evaluating MRI, they have shown that the most frequent implicated ligaments in flat foot would be the spring ligament and the thalocalcaneus interosseous ligament. And that patients with posterior tibial tendon dysfunction, that's a name that we already, we are questioning the name of the pathology. You would have some degree of the spring ligament complex attenuation with a complete tear in 74% of them. So we know that weight-bearing CT can give you a great evaluation of the three-dimensional alignment. And we also know that MRI is gold standard for soft tissue. So why not combine them? I'm just going to give a simple example here. So X-ray evaluation showing the abduction, the collapse of the longitudinal arch, and the valgus alignment of the hindfoot. And if you look to the MRI of this patient, the posterior tibial tendon is not that bad. You have an insertional tendinopathy, very, I would say, low grade or intermediate. I would say it's not that bad for the tendon, but the deformity is pretty severe. Here, looking into, you can see some degeneration of the spring ligament in the coronal views, and also the interosseous ligament, and you can also see in the right side view, the sinus tarsi or the subtalar joint impingement. We can, using the weight-bearing CT, we have the coronal, the 3D. We are not using three-dimensional images here. That's a limitation. That's what we are trying to develop. But you can see the same thing. So you can see, I'm not sure if we have the pointer here, but one of the things that are discussed is the subluxation of the posterior facet of the subtalar joint. The sinus tarsi impingement right here, and seeing on the sagittal view the same thing. So that patient, the posterior tibial tendon was not that bad, and there's a severe deformity with impingement, sinus tarsi impingement. So the tendon doesn't seem to be the main player here. So we have to review our concepts. And these I would like to emphasize again. So the sinus tarsi impingement and the subtalar joint subluxation with subfibular impingement here in this case. This is a different patient, it's not the same patient. And if I have time to get there, maybe I won't have because we already passed the time. But one of the studies, we're looking into the medial facet. And we're pretty sure that medial facet, while we don't have automatic measurements, the medial facet will be a great predictor of patients that are going into collapse. So the posterior facet is not accurate enough to show you when you have, because it's a three-dimensional deformity, you have rotation, translation, all the movements at the same time. Since the medial facet is a tiny joint, what we found is that we can notice the subluxation of the medial facet much earlier than the posterior facet of the subtalar joint. So it might be a good predictor. So this study was a retrospective study, weight-bearing and MRI findings of patients with only stage 2, clinically stage 2. We try to correlate the bone alignment and the ligamentous and tendinous insufficiency. The hypothesis was that we would find significant correlation between the collapse, the markers of collapse in the weight-bearing CT and the soft tissue involvement in the MRI, and that we could potentially predict severity of soft tissue pathology when looking to the weight-bearing CT, and vice versa. When you look to the MRI, you might predict the bone alignment in the weight-bearing CT. And this is just like the dream, is that hopefully this could be a base for in the near future using prospective and longitudinal designs. We could find the predictors for high-risk patients, allowing early and precise surgical intervention, decreasing the thresholds for soft tissue reconstructions that are real there's subject of controversy, like spring ligament reconstructions or deltoid reconstructions, and avoiding the necessity to like, spare the hindfoot. So if you operate earlier, you can prevent subtalar joint fusions or talonavicular joint fusions. So again, retrospective comparative study. I'm going to go for this. We're not going to have time. 55 patients with a mean age of 53 years. We measure a bunch of variables in the weight-bearing CT. 4 blinded independent readers, 2 fellowship-trained MSK for the MRIs, and 2 fellowship-trained for the foot and ankle surgeons for the weight-bearing CT. Total of 25 CBCT measurements were performed, including measurements of arch collapse, forefoot abduction, and hindfoot valgus, especially subtalar joint subluxation, sinus tarsi impingement, and subfibular impingement. And we use, I'm going to go for this. I can give you the details if you want later, but we use the published methods for grading the soft tissue injuries. As a result, we found overall good to excellent intra and inter-observer reliability for both weight-bearing CTs and MRI readings. I'm not going to go into the details of the measurements, but we found similar bone alignment measurements that are already published in the literature, so similar markers of collapse. And that's the most important factors of the study. So in our population, we had 70% of patients with subtalar joint subluxation measured at the posterior facet. 71% of the patients had sinus tarsi impingement, and just 9% had subfibular impingement. And this is very interesting. Also, just demographics of the injuries, but most of the patients had one or degeneration, when you use the degeneration score, 1 or 2 for the posterior tibial tendon, so not bad tendons. MRI for spring ligament, we're talking about the supermedial fibers, most of them were stage 2, 3, or 4. For the talocalcaneum, most of them 2 or 3. So the ligament injuries or the ligament degeneration was found to be higher than the posterior tibial tendon. So again, posterior tibial tendon is probably not a good marker for the disease. So we should definitely stop saying posterior tibial tendon dysfunction. It's just part of it. It's not the reason. And then when we look to the bone marker, so for the sinus tarsi impingement, now we're going to have to give something to the posterior tibial tendon, otherwise this talk would be completely unacceptable. But we found that for sinus tarsi impingement in this population, the only, in a multivariate analysis, the only factor that would correlate with sinus tarsi impingement, that would predict sinus tarsi impingement, would be posterior tibial tendon dysfunction. As we show here, the blue means that they had sinus tarsi impingement, so most of the blues are in 2, 3, and 4 for posterior tibial tendon dysfunction, for degeneration, I'm sorry. Regarding subtalar joint subluxation, both ligaments that we thought would be important were the most correlated factors. So spring ligament, supermedial fiber, talocalcaneum interosseous ligament, and spring ligament inferior fibers. So as we show here, all patients with level 4 degeneration of the spring, we're talking only about the spring here, all patients had subtalar joint subluxation. For the subfibular impingement, the most reliable or the most related measurement in the MRI was talocalcaneus interosseous ligament, a very good correlation, as we show here. If you have a degeneration graded as 1 or 2 of the interosseous, you don't have subfibular impingement for sure. So maybe once the interosseous is gone, then the calcaneus is going to shift completely and maybe hit the fibula. So as conclusions, first study to evaluate correlation between bone, tendinous, and ligamentous involvement in flat foot patients using weight-bearing CT and MRI. And the results demonstrated that the progressive deformity that we can measure with different ways correlated with the MRI involvement, as it was obvious that it should correlate, but sometimes the obvious, you can find results that justify your thoughts. But in this situation we found, and that MRI involvement of the posterior tibial tendon and other important ligaments, even more importantly than the posterior tibial tendon, interosseous and spring ligament were correlated with these measurements, and the implications we already discussed. That we hope that we can bring the threshold for soft tissue procedures such as spring ligament reconstructions or deltoid repairs, or unfortunately we don't have very good techniques for interosseous reconstruction, but maybe we can avoid fusion procedure in this subset of patients with flat foot deformity. I'm not going to go into the details here. I just want to show the image. I already said about this is going to be published soon. It's a very interesting study, case control study. I'm going to go just to the images. But we found, let me go to this. I think it's the most important. So left side is flat foot patients, right side controls. So this is for uncoverage of the medial facet. So we found 45, the average uncoverage of the medial facet in flat foot patients is stage 2, they're all stage 2, is 45% of subluxation. So it's almost 50%, it's a dislocation, it's not a subluxation. For 50%, it's too much for me. But, and in the control group, 4%. So it's a significant difference, and we really think that this, showing the image here just for you to see, the two left sides are controls, so the medial facet is supposed to be completely opposed, and the flat feet patients, and more interestingly, the posterior facet in these cases didn't show that much subluxation, so we think that we were probably using, until we have the three-dimensional evaluation that will show us perfectly, if we want to use two-dimensional image in using the three-dimensional environment of the CT scan, the medial facet is probably the way to go. So I would like to thank my mentors. I was really fortunate and to have just great mentors. Initially in Baltimore with Sean, that is going back to spend more time with him. But in HSS, Dr. DeLand and Dr. Ellis are just outstanding. I also would like to thank my colleagues here of the Way Parent CT Group. Thank you so much.